Hello, good evening, and good morning. and good morning. Hello, guys. Welcome. And today it's an actually first experiment because we are just going to lead some classes in English, and it's about clinical pharmacy and medicine reconciliation. Today we have our guest from Canada, so he's in Canada now. Hello. Please tell me a few things about yourself.
You want me to say a few things about myself?
Yes, yes.
Okay, my name's Jamie. I am a clinical pediatric pharmacist in Ottawa, Ontario, Canada. I currently work at the Children's Hospital of Eastern Ontario. My clinical roles include oncology, pediatric intensive care unit, and total parenteral nutrition, so nutrition for pediatric patients.
And we have to highlight that it's the best hospital in the world where you can do your clinical skills. Yeah,
it's a good hospital, absolutely.
Yes. We say hello to Regis Vaillancourt, the head of the department.
Regis says hello, and he's also the head of the Pharmacists Without Borders Canada mission in Poland. So I've been a member of Pharmacists Without Borders for 2 years now, and I've actually been to Poland to do some teaching.
And it was the best course in the history of Poland, actually.
I don't know.
That's what the statistical analysis says, that it was the highest course, and some people were saying this was the best ever. So, guys, we would like to bring you closer to this education level. And today we are going to talk about medicine reconciliation. As you know, there's a pharmaceutical care pilot running in Poland soon. And we'd like to show you some differences and to get some basic experience about what can happen in the future, basically. So I think let's start. Let's put the presentation on. This presentation will be available in Polish later. And also the material will be translated for people who would like to see it later afterwards. Okay. Thank you very much and enjoy.
Thank you. Okay, I will start my presentation. Can everyone see it?
Absolutely. All fine. Perfect.
Okay, perfect. So again, like I said, my name is Jaime Need, and I am doing it on the patient care process and medication reconciliation. So prior to starting, I just want to send out some thank yous. First to my colleagues, Stephanie Dean, Jennifer Weeb, and Selena Manji. They were an integral part in helping me provide or generate material for this presentation. So a big thanks to them. I also want to say special thanks to Regis Vaillancourt, who is the Pharmacists Without Borders Canada mission lead in Poland. He's giving me the opportunity to be part of these webinars. And of course, a special thank you to Piotr for having me speak today. Okay, so we'll jump right into the presentation. So my objectives today are what I'll be speaking about. So first, I'm just going to provide an overview of the pharmaceutical patient care process. I'll then define medication reconciliation and describe its role in patient care and patient safety. I'll then provide an understanding of the framework to medication assessment and medication use review. I'll then review the benefits of using the patient care process in everyone's practice from both the point of view of the pharmacist and the patient. And lastly, I'll just do a quick review of the application of this process in Canada, so specifically in the provinces of Ontario and Alberta. So first and foremost, what is the pharmaceutical patient care process? So the pharmaceutical patient care process is a comprehensive, systematic approach to provide patient-centered care that pharmacists can deliver in a consistent manner, regardless of what practice setting they are in. So first and foremost, this process is patient-centered. It focuses on the specific needs of each patient and understanding that the needs of one patient may be different than the needs of another. It's also collaborative, meaning pharmacists will work with allied health professionals to achieve the greatest outcomes for their patients. In Canada, collaboration on a multidisciplinary team is common and often includes physicians, pharmacists, nurses, dietitians, and social workers. They all work together in order to provide safe, effective, and coordinated patient-centered care. An important point of the patient care process is the development of a patient-pharmacist relationship. So creating a rapport with your patient is essential in ensuring engagement and effective communication throughout this process. This process doesn't necessarily have a defined beginning and an end, but instead it's a very continuous, fluid process that is centered around the collaboration, communication, and documentation. This process consists of 5 steps specifically, and it's our responsibility as pharmacists to know and understand each step in depth. However, we also need to be able to recognize that each patient situation and principal problem will be different. So how the pharmacist approaches each patient care process will be different, meaning the depth of the steps will be in line with the patient's issue. Lastly, communication is key. Pharmacists must effectively communicate with not only their patients, but potentially patients' families, and also collaboration with members of the healthcare team to ensure the best outcome for the patient. So the overall goal of the pharmaceutical patient care process is to improve patient safety, reduce adverse drug events, and optimize medication use and health outcomes. So here's just a schematic of really how we picture the pharmaceutical patient care process. So as I mentioned, there's 5 steps. So there's collect, assess, plan, implement, and follow up. And they're all, again, centered around that patient care model with collaboration, communication, and documentation. So now I'll just go through each one of these steps in more detail. So the first step in the process is collect. So this includes collecting all necessary subjective and objective information. So it would include all relevant medical conditions, medical and medication history, allergies, pregnancy, and other pertinent information such as tobacco and alcohol use. It includes a collection of information about the patient's issue and why they are seeking help. So it's not just about their medical history, but really why have they come to you today? So we need to collect all that information before we can move forward in the process. So the second step would be to assess. So now that the information has been collected, it's going to be used to assess and analyze the patient's therapies in the context of their overall health goals. By doing this, problems can be identified and prioritized in order to create a plan for achieving optimal outcomes. So the third is plan. So now that the pharmacist has all the pertinent information and a clear understanding of the patient's goals of health, they can create a patient-centered care plan. So this will include collaboration with other healthcare providers within the patient's circle of care. Considerations when formulating this plan are evidence-based approaches and cost effectiveness for the patient. It's important to note that the patient understands and agrees to this plan before implementation. So we're always working with the patient to generate this plan, and they have to agree to it. The fourth step would be implementation. So now that we have the patient care plan, it's now time to put it into action. So this can include communicating with other members of the healthcare team. Communication is key. The fifth step is follow-up and monitoring. So this is where the pharmacist is now monitoring and evaluating the effectiveness of the plan. So is it meeting the goals that were set out for the patient? Does the plan need to be modified now that we've, communicated with the different healthcare providers? And do the goals and actions need to be reassessed and modified to meet the overall health outcomes? So that's the plan kind of in a nutshell. So let's look a little further into each step. So the major portion of this overall plan will be collecting of the most relevant information. So really it's information gathering. So it's important to generate or develop a systematic approach for gathering all this necessary information in order to generate the best possible medication history. So it includes gathering information on, the principal problem. So why is our patient coming to us today? Why are they seeking our help? The second would be patient demographics. So, who is this patient? We need to understand kind of their demographics and also their medical history and medication use. In order to ensure that no information is missed, it's important to develop, again, a systematic approach, which I'll go through today.
Jamie, just a quick question.
Yeah.
What kind of tools are you using basically to gain this sort of medical record? Are you using electronic tools, or are you just using just paper?
Yeah. So in order to kind of generate the information list, like what are we using?
Yeah. The question is basically because currently the sort of pharmacists in Poland, they don't have access to the medical record, and for me now working as a person responsible for deploying services in Poland, we said basically that without gaining access to the medical record of patients, we cannot really provide the patient care, and this is essential. So how it is in your case, basically?
So it actually can vary. So sometimes, especially in a more of a community-based setting, we don't necessarily have access to an extensive patient history. So that's where our pharmacy profiles. So we have a profile on each patient. So we have a pharmacy profile, so we can look back and see what medications they've used, what health conditions we have on file. We can also use their actual medication vials. So often when we're doing this interview, we ask the patient to bring in their medication so we can physically see all their medications in front of us, and we can understand, they can tell us how to take them. When possible, we try to use other information, like we do have provincial databases, but it doesn't include all members of the province. So it's usually for more senior patients. So patients over 65, they'll have a provincial database set up about what medications they have used in the past. So we can use that as well. And also, one of the most important things is just having the patient there, asking them the questions, really systematically generating that information from a patient interview. So there is a plethora of information that we need to get from different sources if available. But again, it varies between patients and between practice sites, so community versus hospital.
So is the hospital patient record basically more detailed in comparison to the community pharmacy?
So some patient records are. So if they have a history at that hospital, they will be detailed, but there isn't a overall patient record that's shared between hospitals due to privacy concerns. Each hospital has their own record, and obviously we can request a patient record from another hospital, but the patient first of all needs to give us their permission to do so. We can also request from the pharmacy. We can request information from the patient's community pharmacy when the patient is admitted to hospital, but again, it's not something that is just open to everybody to get that information. It's a lot of privacy issues. So we always have to make sure that the patient is on board and willing to let us see that information.
And is there like when the patient comes to the pharmacy, for instance, does he need to sign any kind of document that he allows to create a documentation? How it is?
So it is part of the overall documentation process, which I'll get to a little later, but it is something where the participant, so the patient does give us authority to, first of all, to be part of the care plan. So to address this care plan, they're giving us authority to contact their prescriber, and they're giving us authority to generate a profile on them. So overall, it is a lot of the patient giving us the permission and being part of the decision-making that we are helping. So it's collaborative. It's not us telling them what to do. It's them being a part of the decision-making process.
Okay. Cool. Thank you very much. So let's carry on with the presentation.
Excellent. Okay.
I'll just make some interruptions, to make it more interactive, that we just have some questions. I'll just try to relate them to the Polish situation.
Perfect. That's perfect. Thank you so much.
Thank you so much.
You're welcome. Okay, so I just have to see where I was. Okay, so we're gathering information, and now really we have to see, first of all, the patient has come to us, and they've come to us for a reason. So now we're trying to understand, what is their principal problem? What do they need? What are they seeking help for today? So is it a medical condition, or is it a medication issue that they need help with? How long has this issue been occurring? What's the reason for assessment? So why are they seeking help now? And what is their overall goal for seeking help? So what do they want to come out of this? And can it be addressed today, or is it something that we work with the patient down the road and set short-term goals and long-term goals? So that's the major thing, to understand why they're here. And then we move on to really patient demographics. So this would be, just the simple things like collecting their name, age, gender, and their contact information. So their contact information is very important, because we know in the patient care process, there's a follow-up stage. So we have to be able to contact that patient to relay messages if there's any changes in medication therapy and stuff like that. And we also need to know their care provider. So we often will ask them who their family doctor is or who their specialist is. And this is important because as part of the implementation of the patient care process, we need to get a hold of these people. Often, at least in Canada, if your patient is coming to you from in a community pharmacy, we often have many of these patient demographics already like in our system. So we know the patient. So we've collected this ahead of time. But if, it's a new patient coming to us, it's important to gather this information first. So that's our first. And then we move on to a more in-depth process of gathering information kind of about their medical history and their kind of medication or medical, I guess, level at this point. So in Canada, we use something called CHAMPS. So it's a really good analogy. It's a really good a list to remember. So we're doing it systematically. So we're asking all pertinent questions. So CHAMPS, obviously conditions, history, allergies, medication, pregnancy, and signs and symptoms of their current issue. So conditions. So C is for conditions. So we're asking, we want to know what is the patient's medical background and what conditions do they have. So when we're thinking of this, we need to think from a head to toe model. So we're thinking, do they have any issues for the major organ systems? And also we can help to prompt them as well, because often they may forget. So we like to go head to toe. So examples would be like hypertension or diabetes, cholesterol, or seizure disorders. This is a more extensive list. Again, we wouldn't necessarily go through each step of this list, but when we're collecting information, we just want to make sure we're thinking head to toe, and we're designing this collection phase based around the needs of the patient. So now we move to H. So this is history. When we talk about history, we really need to break it down into various types of history. So first, we think medical history. So we're asking, are there any important events in the patient's medical history that give us more insight into the current issue or their medication use? So for example, has the patient had an organ transplant? Has the patient had a history of stroke or a history of heart attack? These are really going to help kind of give us a better understanding of the current medical condition of the patient and also help us in generating therapies down the road. Next, we look to social history. So again, these can be very influential on their current situation or their medical history. So when we're asking about social history, we need to be sensitive about the nature and the relevancy of our questions, but it often involves, do they smoke tobacco? What is their alcohol use? We may ask about illicit drug use or sexual history if it's relevant. Another good one is to ask about nutrition and exercise, because again, it's not all about medication. It's not about giving medications, but it's also about like those non-pharmacological ideas to help with their overall health.
Yeah, Jamie, we can actually explain a bit as well why this is needed, because maybe people don't understand why we just have to analyze the social background, because the social background, for instance, I just remember this case study actually, which I had to do myself when I was doing my practical training in Australia, and there was a lady, a young girl who was like 16 years old, and she was admitted to the hospital with acute kidney rejection, transplant rejection. And basically one of the problems was that parents were not feeding her well, and she was feverish, everybody was ignoring it, nobody was taking care of her, and this was actually causing that first of all, she didn't take medicines because she was feeling bad. There was a lot of side effects as well because she was taking things on empty stomach. So all this we have to just, I think, explain to people that this is a very structured interview, but this is all necessary because in the outcome, basically, the medicines will work better, and also the compliance is important. For instance, especially regarding kids, this is something that is very, very important, because when parents don't look after the children, they can have potential problems from not taking medicines, for instance, or taking too much. So this is all important, what we are just now talking about.
Absolutely. And we're always trying to, again, put it back to the specific patient, but you're right, it can have such an influence on the overall medical management of this patient. So even nutrition and exercise and diabetes, type 2 diabetes can often be managed with, better nutrition, better exercise before turning to the second and third line agents. So these are really important questions to ask so we can build that into their patient care plan down the road.
Another example, like tofilin. Yeah, this is the medicine used in asthma, and this the tobacco smoke basically influences the levels of this medicine in the plasma. So this is extremely important, because basically when the doctor is monitoring this level of this medication in the blood, the smoke, cigar smoke, basically sort of improve the process of eliminating it, and then he gives bigger doses. The bigger doses means more side effects. So it's all very important. Just try to explain to our audience today why it's so important, and it's not like kind of being fussy. It's just something that needs to be done to be able to assess the person medication therapy.
Absolutely, and that's a great example. Exactly, it's as important as asking about medication, is asking about kind of what else they're doing beyond their medication, for sure.
Yeah, cool. So let's come back. Okay. I'm sorry, I'm just trying to.
That's okay. I appreciate it. I really I appreciate it.
People. So thank you very much, and sorry for interrupting.
No, don't be sorry at all.
All ears.
Okay, and we'll move. So family history. So we also will sometimes ask about family history because that can provide insight. So there may be like a family history of disease. But we can also ask in terms of there may be changes to their family structure, or they may have suffered a loss in their family that is influencing their overall health today. So it can vary quite a lot with the family questions. And then we move to functional history. So really, does the patient have impairment secondary to a previous event or health issue that is influencing their health now? So for example, has the patient had a stroke in the past and now they have difficulty swallowing? So now they have difficulty swallowing and they can't take their medications as prescribed, or they have, they require some supports in the home, but there's no support. So how does this influence their overall health? So these are really important things to ask because they're not necessarily obvious when we're speaking to a patient. And lastly would be occupational. So we can ask them if they've ever had some sort of hazardous exposure, or they have stressors in their occupation that would contribute to the issue that they're seeking. So history can sometimes be a bit of a long section, but it also can be very quick depending on the patient. And then we move to allergies. So allergy status of patients is always important to be aware of. So not just during the patient care process, but anytime we're distributing medication, we should always ask the patient if they have any allergies to medications. But it's especially important when we are recommending therapies. So again, with allergies, they can be broken down into 3 categories. So medications. So do they have allergies to medications? Do they have dietary allergies? So for example, lactose or gluten, which can be found in excipients of medications. So that would have a huge influence. And do they have seasonal allergies? So we can think about non-prescription therapies that we could help out if that's their issue that they're seeking today. When we're asking about allergies, it's always important to ask, what are the signs and symptoms of their allergy onset? How do they manage it? How often does it happen? And have they had reactions to medications within the same class? So asking about severity and previous reaction history is also important in assessing whether or not we can really consider this a true anaphylactic reaction or an intolerance to a medication. So now I'm going to jump to P. I know I've skipped M, but M is important. So it's medication, and we'll talk about that in a minute. But I'm just going to skip to P. So P is for pregnancy or breastfeeding. So many medications are safe in pregnancy, but others may need to be avoided in certain trimesters or even the entire pregnancy. So we need to know, is our patient pregnant? Because again, that may not always be obvious. Again, we have to take into account that we're thinking about the gender and the age of our patients. So we're not asking every person if they are pregnant, because clearly a man would not be pregnant. And also we need to ask about breastfeeding. So they may not be pregnant, but they may be breastfeeding. And we know that, some medication, or a lot of medications actually get into the breast milk, and some are safe in certain quantities, but some are not, and some need to be monitored. So these are important things to ask, especially, again, when we're recommending therapies, we need to be aware of their situation. And then we move to signs and symptoms. So really, it's about the issue they're coming to us today. So we need to ask about, more about that issue. So really, this portion, we use another set of letters called SCHOLAR. So it's really an interviewing framework that guides our pharmacists to ask like a series of questions with subsequent analysis in order to assess the patient's problem. And to establish if the patient is able to able to carry out self-care, and select the most appropriate prescription and non-prescription products. So I'll just quickly go through this as well. So S is for symptoms. So we're asking, what are the symptoms they're experiencing today, and what are the main symptoms they experience with this present illness? So C is characteristics. So what are the symptoms like? So we're asking open-ended questions. We're saying, describe your symptoms. Tell us about the intensity, the severity, the patterns of this illness. And then we're asking history. So what has the patient tried in the past? So what have they used in the past to see if this helps with this illness? Have they tried medications? Have they tried non-pharmacological means? So it's important to ask just so we know when we're making a plan what to do. We also ask about onset. So how long has it been? When did it begin? Is it something that comes and goes? Is it something that has been happening all along? What's the frequency or length or triggers? What is triggering it? So what is that? A is aggravating, so what makes it worse or precipitates the symptoms? And R is remitting, so what makes it better or prevents the onset? And then the last one is it's considered the explanatory model. So really, it's what does the patient believe is causing the symptoms? Because we always have to turn it back to the patient. We can't just be objective the entire time. We have to be subjective and say, what do you think is causing the symptoms? How are the symptoms affecting you? Is this proving to be more stressful or causing even more issues medically?
Jamie, just a quick question.
Yep.
This is just about basically to explaining our audience today, our pharmacists, and where is this performed? Is it before visiting the doctor?
So when a patient comes to us in a pharmacy and they're asking, I need something, I'm having an issue with a medication or a medical condition, I need your help. This is when we're sitting down with the patient and we're going through our CHAMPs. So we're doing our conditions, our history, allergies, medications, pregnancy, and symptoms. So at the interview with your patient, this is when you're doing it. So this is when you're asking. You may not go this in depth, but you're asking about that, that side effect they're having, because you need to know more about it.
And this is also basically important because it's a standard procedure. It's like everybody does the same way. And
absolutely, yeah. Okay. And it's meant, so I'm providing these kind of systematic approaches. So CHAMPs and SCHOLAR, it's a way that when you're in front of any patient, you can go through in your head to make sure you're not forgetting to ask questions. So even in pharmacy school in Ontario, at least, this is what we learn. So we learn these acronyms so that we know what questions to ask and in what order. So we're systematic and we're never forgetting something. So CHAMPs and SCHOLAR are really big teaching points for us.
This is something I wanted to highlight for everybody who's listening today, definitely from Poland, that the interviewing the patient is always a structured interview. So the questions are always one by one, are always the same way, because this is the only way you can get the most information about your patient to help him later. So this is what I just wanted to summarize. Okay, let's come back to the presentation.
Excellent. Okay, and now we move to medication. So we're pharmacists. Medication is important to us. So we're going to dive into the medication portion. So when we're thinking of medications, we really, again, we want to divide it up. So prescription medication, non-prescription medication, and vitamins and herbal supplements. So we ask the patient about all of these. So then now I'm going to go through how we would do this. So technically it's called a the medication reconciliation or medication use review is a common term used in Europe. It requires a systematic and comprehensive review of the medications a patient is taking to ensure that medications being added, changed, or discontinued are carefully evaluated. So the process of determining the medications a patient is taking is known as the best possible medication history, which is it lives within the medication reconciliation. So before we can really implement a medication reconciliation, we have to get the best possible medication history. So this is us asking about the prescription, non-prescription, and herbals and vitamins.
Mhm.
So really, we call it a BPMH. So our goal is to obtain really a complete list of the medications a person is taking. So for every medication, we need to know what is the name of the medication, what's the formulation, what's the dose, what's the route, what's the frequency, what's the indication, and any special consideration. So is the patient taking it with food? Is it supposed to be taken without food? Does it have a stop date? So for every medication the patient is taking, we record this because it's so important moving forward about identifying a drug therapy problem and about implementing the plan and setting goals for the patient care process. In addition, often patients will consider medications are something that are taken only by mouth. So instead of saying, I have eye drops and ear drops, but I'm only talking about the medication that I take by mouth. So as pharmacists, we need to ask those important things. We need to say, are there ear drops, eye drops, sprays, inhalers, patches, ointments? We also ask about immunizations because we want to know, have you been immunized? Are you getting a flu shot? That sort of thing. So we want to know the whole picture in terms of what they are currently on or what has recently, what they've recently taken. So for the best possible medication history, it needs to be a comprehensive look into that. Oh, sorry. So tips for interviewing the patient. So really, now we're sitting there and we're asking them all these questions, but we really need to have a good structure of how to do this. So we need to be proactive. Really, we need to gather as much information as possible prior to seeing the patient. So like Piotr had mentioned before, or had asked before about what we do in Canada. So we try to get as much information prior to meeting with the patient, just so that we're maximizing our use of time when the patient is actually in front of us. But it's not always possible. So sometimes patients are just coming to our pharmacy for the first time. So that's when we're collecting all the information. But if they're a recurring patient, we might already have that information. So we're just being proactive. We're getting ready for our interview. We're having as much information as possible in front of us. And then we also will ask the patient to bring in medication vials or lists if possible, so we can understand what they're taking. We also want to prompt questions about non-prescription categories. So over-the-counter medications, or what they're called in Canada. We also want to ask about the vitamins, the recreational drugs, and the herbals and traditional remedies, because often patients, again, don't consider those medications, so they may not tell you about them. And thirdly, don't assume patients are taking medications according to the prescription vial. So a patient can show you their box of medication or their vial of medication, and it says, take 1 tablet twice daily. But we can't assume that the patient is actually taking it like that. We have to say, tell me how you're taking this medication. We use those open-ended questions and say, tell me how you take this medication, which is my next point, use open-ended questions. So this just gives us a better understanding of if there is any discrepancy between how a medication was prescribed and how a medication is actually being taken. So that gives us really good insight into their overall health goals. And we have to consider patient adherence. So, when was the last time they filled these prescriptions? Why haven't they filled these prescriptions? There's many issues with adherence, and that also gives us a good insight. So we have to be very diligent in asking about adherence. And then in Canada, we verify accuracy when we can. So we're trying to validate with 2 different sources. if possible. So again, we look at medication vials, we look at the patient profile. If there are a patient in a pharmacy, in a hospital, we'll look at their chart. So we try to validate with 2 different sources, or we can ask family members as well, if possible, depending on the situation. So this is really when we're documenting each medication, this is what I'm talking about. So documentation is such an important part, an aspect of the patient care process. So we have to ensure that you're documenting everything appropriately and completely in order to create the most accurate and up-to-date patient record. So for example, as you can see here, so we have rosuvastatin. So we have the medication name. We have the dose. We have the route. We have how they actually take the medication, so the frequency of the medication, and what it's for. So when we're asking the patient, okay, rosuvastatin, how do you take it? They'll say once in the evening. What do you take it for? For my high cholesterol. What's your dose? 5 milligrams orally. So it's something we're asking, and we're saying, tell me how you take it, versus just reading their prescription vials. And we always want to make sure, again, that the documentation is very complete, because it's easy to remember in the moment when you're discussing with the patient, and you think you'll remember later on, but then when you go and review your documentation later, you may have missed something, or you may have used an abbreviation that doesn't make sense. So the ISMP has set out a list of do not use dangerous abbreviations when documenting, just because it can confuse things. So for example, a common one that we see is OD. So OD is once daily. Or we see it often used as once daily, but unfortunately it can be confusing because it also means to be put in the right eye. Yeah. So it's something, it's just these things in terms of documentation, because documentation is so important in the patient care process. We have to make sure we're doing it completely and safely for the patient.
Jamie, do you have something like a good prescribing practice that, for instance, that's obligatory, mandatory, that the doctor is always putting the right directions for use on the prescription? Because, in Poland, sometimes it's not right, and the doctor can put, for instance, to save a bit of money for the patient, he can put the dose super high that he can get more per prescription. But I'm not sure. I mean, I know in many countries around the world, there's a good prescribing practice that the doctors always needs to state the direction for use, that the strength of the medicine, what is it used for, and it always must be on the prescription, and then it must be repeated on the label as well, that the patient knows everything.
Absolutely. And there are good prescribing requirements in Canada. So at minimum, again, we require the name, the dose, the route, the frequency. We do ask for indication, but it's not always evident. And again, we ask for the amount, and we do refills in Canada. So our patients come back to us for a refill prescription. But yes, I mean, even with the good prescribing principles, people still use these abbreviations, or they will try to kind of get around it. And it's sort of, as pharmacists, it's our duty to really be diligent and contact those doctors if we need to clarify, because patient safety is number one. We always, especially with medication, we have to ensure that the patient is safe and is taking the right dose, like how it should be prescribed for the right condition.
Okay, cool. That's what I wanted to highlight. I think this is important.
Absolutely. It's incredibly important for patient safety. So these are just, I have 2 slides with just a couple examples of like how a best possible medication history may look. So this is actually at a hospital. So this, as you can see, we've asked for the medication, we've asked their dose, we've asked the route, and we've asked the frequency. So this is how we would document. Mm-hmm. There's another one. So again, this would be more in the community base, where we're asking all of that and indication. And the comments are very important, because that could be where the patient is saying, I only take it if I have a headache, or I don't take it how my doctor tells me I take it this way. So it's important little tidbits that we need to know specific to the patient.
Excellent.
So now that we have kind of our best possible medication history, so we have all our information, and we have we've collected all our data, a medication reconciliation and clinical medication review can be carried out. So it's really, we're moving to the assess phase of the patient care process. So this process is done to ensure accurate and comprehensive medication information is communicated consistently, and issues relating to the patient's use of medications are addressed in the context of the clinical conditions in order to improve health outcomes. So really, when we're assessing, we're doing 4 main investigations. We're looking at indication. Is the medication indicated for the patient? Efficacy. So is the medication effective for the patient's medical condition? Safety. Is the patient's use of the medication safe? Are they experiencing or are they at risk of experiencing adverse side effects or drug interactions? And then adherence. So is the patient taking the medication as prescribed, or are there barriers to use that are actually causing detrimental effects to the patient? So these 4 areas are really how we assess. So now we have our list of medications, our best possible medication history, and we are assessing based on indication, efficacy, safety, and adherence. So I'll just go through them.
Yeah.
So first we're saying, is the medication indicated? So, our patient tells us that they're using a number of different medications, but now we're evaluating if the medication is appropriate for the patient. So does the patient have a medical condition that the medication would be indicated for? Is the medication that they're taking the optimal therapy for the medical condition? So also known as, is this medication first-line therapy for that medical condition? If it's not first-line therapy, is there a justifiable reason why they're using this medication? So, have they tried and failed a first-line therapy and now they've moved to a second-line therapy? Is it justified? And we're also thinking, is the dose appropriate for the indication and the patient? So yes, there are dosing ranges for many different conditions, and we have to say, does the dose fit the patient and the indication? If we really can't ascertain the indication, we have to think to ourselves, can this medication be discontinued? So is this medication really right for the patient now? And this is where I just want to talk about something called De-Prescribing. So quickly, just an aside. So really, as members of a patient's healthcare team and as the medication experts on those healthcare teams, pharmacists are responsible for not only ensuring appropriate medication therapy, but we're also really an integral part in identifying when medications can be or should be discontinued. So we always have to remember that a medication was maybe at one time right for the patient, but may no longer be providing benefit or is indicated whatsoever. So, a patient could be taking a medication, continue to take a medication, even though it's really the issue is over or it's actually causing more harm than good. So this deprescribing.org is a really great reference or online resource for anyone interested in kind of reading further about our role as pharmacists in targeted deprescribing. So we're not just about getting patients on medication, we're also very important in getting patients off medication. So that's all I'll say about that. But I feel very strongly about deprescribing and the importance of this.
This is definitely a good example how to basically save life of people who taking too many medications.
Absolutely. So second step. So now that we kind of have an indication for each of their medications, we have to really look, is that medication effective? So when we're looking into efficacy, it's important to consider, like, what are the patient's goals of therapy, including their treatment targets and patient's outcomes. So when we think a diabetic patient, we have to say, is this medication for diabetes proving to be beneficial for the patient's blood glucose levels or hemoglobin A1C? Or, for patient outcomes, like more subjective, is the medication effective at treating, for example, patient's pain, so that to a point where they have increased activity and functions of life. So we're looking at subjective data. So things like if we have that available resource, so more in a hospital, I would say, where we can actually see lab results. And then we look at subjective. So we're asking the patient, like, how do you find that this medication is working for you? Tell me, do you think it is effective? So it's good to kind of gauge from the patient, but also the objective data. And if we decide that it doesn't really have a lot of efficacy, we have to wonder why. So this is when we're asking ourselves, why isn't the medication effective? So there can be many reasons. So a medication can be or appear to be non-efficacious if there's non-adherence. So really, is the patient not taking it, first of all, as it should be prescribed? Or does the patient need additional therapy? So at one point they were okay on this therapy, but they need something else in addition to the therapy they're already on. Are there interactions with other medications or other foods resulting in poor efficacy? Are there issues with absorption of the medication or onset of action that are making it difficult to determine efficacy? Is it a formulation issue? So, is it a puffer not being, like an inhaler not being taken correctly? Is it an expired medication? So it's non-efficacious because the medication has expired. So it's just poor quality at this point. So efficacy, we can't just say that medication is not right for that patient. We have to say what's happening where we're not getting the effect that we should be getting. So we have to dive into this more. And that's, again, we're asking the patient about these issues. And then by determining the reason a patient is non-adherent, we're able to structure our care plan around this. So if it's non-adherence, I guess I'll get to non-adherence, sorry. We're going to look at medication safety as the third one. So even if a medication is indicated and effective for the patient, it may still not be safe for the patient to use. So, they have a medical condition where it's indicated and they're having effective outcomes. So especially in an objective manner, their blood glucose is within a good target range. We have to think, is it actually safe for them? So especially in terms of dosing, because as we age and as we change, again, like our body composition changes, our organ function changes, our weights can change. So these can all be huge triggers for the potential for harm with medications. So we have to ensure that we're really taking that into account. We also have to think about drug interactions. So there's so many risks for interactions between drugs, between food, between like disease states, and also with testing. So for example, warfarin and INR testing, we have to ensure that the dose is appropriate and they're getting the appropriate lab results. So once the safety issues have been identified, we then have to determine, can these risks be managed or does it require a change in therapy? So we're always thinking, does it require a change in therapy, or can we somehow help the patient moving forward to be safe? And then lastly, we're looking at adherence. So next what's the issue with the patient's ability to take the medication as prescribed? So often, if there is an adherence issue, it's deeper than just them not taking it right. We need to know why they're not taking it right. So common reasons for adherence issues would be adverse effects. So they don't want to take it as often because they're having side effects to it. It could be dosage form or frequency. So dosage form, it's an inhaler and they have some issues with actually using an inhaler. So they haven't been taking it right. Or frequency, that medication has to be taken 4 to 6 times a day, and it's just not really conducive to their day-to-day lifestyle. Cost and drug accessibility is a huge issue, even in Canada, where is the patient able to pay for the medication? Is the medication covered by some sort of insurance plan? Or is the medication on back order from the manufacturer? So, the patient wants to take the medication, but can't actually access the medication. Another important one is patient beliefs. So patients may not understand or believe that they need a medication because they can't necessarily identify the medical condition. So often I've seen patients who have come to a pharmacy and they don't understand why they're taking a medication for high cholesterol because they can't see or feel the high cholesterol. They just know that their doctor's telling them based on blood work they have high cholesterol. So patients may not take the medication as they should be because they believe they don't need it. Or they don't understand the directions. They don't understand that they're supposed to be taking it every day, but instead they're just taking it a couple of days a week. So it's really important to ask them how you're taking it instead of, are you taking it this way, yes or no? And then the last one is really just the patient's ability to self-administer. So again, going back to that functional they have COPD where they can't actually inhale an inhaler because their inability to take a deep breath. So these are things we have to really look at in order to identify the real reason why they're adherent. And then again, we need to ask, can these adherence issues be managed, or do we need to change therapy? So those are kind of the 4 steps in assessing. So you have your medication list, you collect all your data, and now you've assessed each medication on indication, efficacy, safety, and adherence. And now we check back. So now we've gone through the collection, we've gone through assess, and now we generate our plan. So this plan will address medication-related problems, and it's going to optimize the patient's medication therapy. So it's also meant to really set goals of therapy for the patient for achieving clinical outcomes in the context of the patient's overall health goals. It's also like part of your plan should be providing education and empowerment to the patient in regards to managing their health. So we're working with the patient in generating this plan. So we're saying, here are kind of the medical issues that we can, communicate to the prescribers and change therapy if needed. But here are all the education pieces that we can provide in the meantime. Here's the empowerment that we can give to our patients. So this is a very important part of generating the patient care plan. And once we generate the plan and the patient has agreed on the plan with us, so it often in community includes the patient signing a document saying they agree to that plan, then we implement it. So implementing it is really, typically involves contacting the prescriber if a change in therapy is required. So one major thing is how do we communicate with different healthcare providers? And again, we tried a systematic approach so that it's the same way every time, and we're working in a way that is the most efficient and ensures the best quality of care and communication. So one tool that we like to use is called SBAR. So it's an effective tool for framing a healthcare conversation. It requires a clinician's immediate attention usually, and it allows a really focused approach for communication between members of the healthcare team. So as you can see, it's another acronym. You can tell we love acronyms in Canada. So the first one is situation. So this is when we're maybe drafting a letter to the doctor, or we're going to call the doctor. This is kind of how we're thinking about approaching the doctor. So first is situation. So what we're going to say is we're stating the problem of the patient that we've seen. So this medication is not right for the patient, and this is why. So we're giving a background. So we're saying a brief description of the information related to the situation. So this is kind of where we're stating why the medication wouldn't be right for the patient at this time. And then we're giving our assessment. So we're saying we've analyzed the problem. These are the options that we have considered. And then we're making our recommendation. So we're making a firm recommendation to the doctor. And we're not just giving them options. We're saying, as a pharmacist, this is what I recommend. This is the change in therapy, the change in dose, the addition of a therapy. We're being very clear. And overall, this process is a very concise, clear way to communicate to the healthcare team about the recommendation you're making as part of the patient care process and as part of the patient-centered care plan. So once you've made your recommendation, it doesn't necessarily mean that the prescriber will agree with your recommendation, but it's important that you've made the recommendation, you've documented your recommendation. Again, documentation is very important. So yeah, that would be the kind of implementation portion. And then we check back. So now we've implemented it. Now we go to follow-up and monitoring. So this is us really checking in to evaluate the effectiveness of the care plan. So this is when the plan can be modified. So now, we've spoken with the doctor, we've made our recommendation, they've accepted it, they've suggested something else, they've rejected it. So now we look at our plan and we evaluate, do we need to modify the plan in collaboration with other members of the healthcare team? Do we need to check in with the patient ever so often? If it's a new therapy, we're providing education, we're checking in with the patient to see how they're tolerating the medication. This doesn't necessarily mean that we have to call the patient. We can see the patient the next time they come in, or we can call the patient, that sort of thing. So we can follow up in a number of different ways. But follow-up is always important. So every time we've made some sort of change, we've implemented some sort of change with the other healthcare providers, it's important to follow up with the patient, because they need to know what changes have been made and what changes will be best moving forward. And as you can see, this process doesn't just stop at follow-up, it's a continuous process. So again, we can go back around this with patients and we can collect more information about their new medication. We can assess it. We can make a new change to their care plan. And again, we can implement and follow up. So it's definitely a continuous process for each patient that can change, all the time, pretty much.
Yeah, the outcomes of the treatment.
Absolutely. So really, I know this seems like a big process, but it does have benefit. It has benefit to both the patients and to the pharmacists. So really the benefits for the patient are improving the patient's understandings of their medications. So what they're for, how to take them properly. So now we've sat down with them, we've been able to provide them education about how to take their medications, what their medications are for, which often is the most important thing, because patients will get medications from their doctor and not really understand why the doctor gave them that medication. So it's our responsibility to give that information to the patient. Also, they can benefit because we can identify potential issues with the medications they're taking, and we're helping to reduce risks at the level of the patient. So right away, we can identify drug interactions. We can identify interactions between prescription medications and non-prescription medications, which are often a cause of issue in Canada just because of all the medications that can be bought over the counter. We're also generating an action plan for improved adherence and reducing side effects. So we've identified why they're non-adherent. We've made a plan going forward to improve their adherence and also reduce those side effects if there are any. And we're following up with the pharmacist, or the patient is following up with the pharmacist, to ensure that compliance and efficacy. So again, we're being that support for our patient, and we're ensuring continuous optimal health goals are being met for our patient. This is really important to supporting our patients. So what is really the benefit of us as pharmacists? What do we benefit from doing this? So it's really improving patient satisfaction and retention. So patients are able to go to whatever pharmacy they want, but if we are providing these services to them, we are ensuring that there is patient satisfaction, that patients are coming back to us. So patients, we have a group of patients that are now more likely to return to our pharmacies. And also we can help patients not only with their prescription medications, but also choosing non-prescription and vitamins and herbal products that are going to be safe with their current medication regimen. So now we have a plan of care, and if they want to come back to us to ask, they're buying things from our shelves. They're buying, the non-prescription medications that will be safe with their prescription medications. So again, it's a retention, and it's potential improvement of sales for our non-prescription items as well.
Sometimes I'm just thinking that is it all not about the money, basically. The money is just important because many times pharmacists in Poland are asking me, okay, what about my money? Come on, when I have to do that and this. And this is not all about the money. I mean, this is the general concept of performing the life of pharmacists, basically. You are doing for the patient, and then basically automatically, if you perform more responsibilities, your remuneration will go up. This is something obvious. And this is just the problem now we have in Poland, that we don't facilitate this kind of condition and this kind of procedures for you to perform basically on this level. And this is very simple. Basically, implementation of this kind of services is very simple because they are already done in other countries, and this is just sort of transposing it one-to-one, maybe slightly amended. And this is just a matter of changing the training and getting pharmacists more involved. And obviously the remuneration. So the service must be reimbursed from the government. So the government must pay for that, because the government will need to just feel basically the zest of the benefit. And this is the most important, to show that, if just think about it, if we have 20,000 pharmacists in Poland and all of them will start to do medicine reconciliation, they will start to think and find mistakes, prescribing mistakes, basically problems with adherence. For instance, that the patient cannot swallow Keppra tablet, which is like half of the finger, and this is understandable that they cannot swallow it. So the pharmacist will say, doctor, please give him a liquid because he cannot swallow, it's too big, or another condition when the patient is taking a bath, but actually his medicines are for taking a shower, for the eczema, for instance, atopic eczema, and obviously he's not going to have effect because this is a completely wrong form. And the personal beliefs, for instance, when the patient is just like a young guy who is just being treated from psoriasis, and he's like, the doctor prescribed him how disgusting, smelly products, and he doesn't want to use it, and he's just trying to date girls. Obviously, he's not going to use it. He's going to suffer then. So this is where the pharmacist is, and where his role is in the system, and the government needs to basically pick this up, this little thing that it's important, what the pharmacist can do for the patient. So,
absolutely, it's beyond just dispensing medications. It's about ensuring the overall health of your patients, because if you're able to show that by doing this patient care process and by having the retention of patients, you're able to actually reduce healthcare expenditure for patients. So this is what has happened in Canada. So in Ontario, pharmacists have been given more kind of professional pharmacy services, because we have proven that by doing these services, it actually is improving patient outcomes and reducing the burden on the healthcare system overall. And that's why we've proven to the government, and they've given us kind of more services over time, in order to, and again, we get money for those services. There is remuneration. So it's just, people will get money, but it's also about patient care. It's about your patient. You are a healthcare provider, and you need to do the best you can for your patient.
And Jamie, are you happy with your salary? I mean, this is just a question from today, because people were asking me how it is, how they will benefit in the pharmacy when the services are there, when the pharmaceutical care is there, when there are plenty of services. They were asking me, where will they get the money increased? I mean, if the money will go up. Obviously, the money will go up because you will get more responsibility. Don't expect to get paid when you only dispense the boxes, because this is the same like going to the super shop, basically, when you just get food. The same thing, So if you add additional value, for instance, if the lady at the counter in the shop would give you additional advice about dietary suggestions, then basically this is additional service. So this is the same way. You don't pass boxes, then don't expect more money. If you go more clinical, if you do more job that it's worth for the system in general, for the healthcare system, then basically your money go up. So this is the main case, how the system works, basically. And something just to think about, basically.
Yeah, absolutely. It does reflect in our increased salaries, because you are providing more of a clinical role on the team. So, the work you do is going to be reflected in the salary you make. Absolutely. So it will enhance. And that actually brings me perfectly to an application in Canada. So in Ontario, we have the Meds Check program. So we call it Meds Check. So what it is really us sitting down with the patient, each patient, and we're doing our patient care process. So we're going through all of those steps with our patients. So it was launched by the Ontario government. So our healthcare is provided provincially. So it was launched by the Ontario government in 2007. And it was our first professional service that we were able to do as pharmacists. And since then, so it was so successful that now it's been expanded. So now we can provide it to long-term care patients. We can provide it to homebound patients. So this is when pharmacists actually go and do house calls. We also have specific medication or meds checks for patients with diabetes, and for different services. So we've proven that it's helpful for our patients' safety, our patient outcome, and it's also providing a service, taking the burden off the healthcare system, taking, both the burden from the doctors, but also the burden from the government to provide that money for care. So we have shown in just over a decade that we as pharmacists, we are helping improve the healthcare system in Ontario. As well in Alberta, well, most provinces have a similar process. They just call it something different. So in Alberta, it's the standard medication management assessment. And again, it's different costs. So I'll actually review. So in Ontario, where I live, these are the different payments. So each time we do a meds check with a patient, just an annual meds check. So each patient would be covered for one meds check per year. We get $60 per meds check on top of our dispensing costs and everything like that. If
okay,
we do
here, because it's a question from our pharmacists, and they're asking me whether this money goes for the pharmacy owner or for the pharmacy business, or it goes for you. How it is?
So that is very dependent on the pharmacy. So it's often something that will go towards the pharmacy department as a whole, but sometimes certain pharmacists, they're kind of
incentive.
They are there to do meds checks, or if they're doing homebound meds checks or something like that, that is their personal payment. Some pharmacies will also just pay the pharmacist, like they will gather all the income from all of these meds checks and distribute it evenly among the pharmacy members. It's very different per pharmacy. Hopefully, the owner of the pharmacy would not take all of this money because unless they're doing every meds check. But in an ideal world, it is split between the different pharmacists.
Mm-hmm. Just a question. When you feel happy as a pharmacist, because I was feeling happy as a pharmacist when I was getting good money and doing the great job for people. When I could combine the good income plus generally the really good mission and that I was really happy with my role, helping people, hearing the good sort of word from them. This was the perfect happiness for me. So do you think this is important, that the good remuneration plus the expanded role? So this both things come together as a satisfaction from work?
Absolutely. I think being more clinical and being able to offer those services to our patients directly is a reward in itself. So yes, money is important because we all need to live, but it's not the be all end all for me. I think providing direct patient care and seeing my patients, talking to my patients, having them come to me for an issue is almost more important than any sort of money I would make from this. So this is overall, I got into healthcare in order to care for people. So it's very important to me that my patients are safe, healthy, and I'm helping them along their way.
There's Małgorzata saying that she never been getting money for meds review when she worked in Alberta as a pharmacist for 7 years. I mean, I just give an example because I know that in different states, basically, it's a different thing. And myself, I was rewarded. Every first and medicine use review was I was getting £5, and then basically over 10 I was getting another 10. So half of the money was going to the pharmacy. But as I said, we just discussed it with Jamie. The concept, it depends on the employer and local arrangements. Let's put it this way.
Yeah, and sometimes you might not see money directly from these, but that money might be, it's being put back into the pharmacy. So now you have, better services that you're providing. You have more pharmacy members on staff so people can actually sit down. So this money can be going back into building the pharmacy, the clinical role of the pharmacy. So now you have more technicians working so that you have more time to actually talk to patients instead of you're filling medications. So you don't necessarily see it go directly into your pocket in all of those instances, but it will go to the pharmacy as a whole. So when I work in community, or when I previously worked in community, so I would get money per meds check that I did. It would come as a bonus depending on how many meds checks I did. But as the company whole, some of that money was also put into the put back into the pharmacy department so that they could hire more pharmacists. So more pharmacists could be providing more clinical meds checks and stuff like that. So money is being put back into these services to ensure that we can expand them going forward.
Cool. Thank you very much. So an hour is gone, Jamie.
Yes, I'm done. I'm done.
An hour is gone. So I think it was a great piece of knowledge for everybody. And we are waiting for your comments as well. If you like this way, and if we should carry on, because next week we are going to do nephrology, and it's going to be also a very advanced course. Today was just a beginner course, and next week we are just going to go slightly advanced. This is something to do with our project as well, to teach pharmacists English as well. Some of you, they requested it, so this is also a good concept. And obviously, Pharmacy Without Borders is one of the greatest projects on the planet regarding pharmacy education. So we could basically get in touch with people from other countries who are clinical trained, they have lots of experience, and they could share with this experience with the Polish pharmacists. We are just at the beginning of our way. I'm talking about those who never traveled abroad or just never been working abroad, because this is obviously different, and many of us, unfortunately, never done this kind of experience. So I think it was a very good piece of knowledge. And there was a good question just in the end. How long does it take to perform the meds check or medicine use review?
So for a meds check in Ontario, we usually try to take between 10 and 30 minutes. And that's just for a basic meds check, an annual meds check, but they can go longer. Sometimes we will invite them to come back. We'll make appointments. So this again would be when more money has been put into the pharmacies. So now more pharmacists are hired to do just specifically meds checks often. But we try to aim for 10 to 30 minutes. And I know it seemed like a lot of information, like how could you possibly get through that information? But as you're asking questions, you can start kind of removing things from the list that aren't pertinent to that patient. And just another thing to note, like I know it seems like we're quite advanced, but in terms of like Canada versus Poland, but just remember our healthcare system, and especially pharmacy, was very similar to Poland a couple of decades ago. Like we've made huge strides in pharmacy, in our clinical work, in our clinical services in the past couple of decades. So it's not something that's unfathomable for Poland now.
So I'll tell you something interesting. Do you know that since 31st of March this year, pharmacists, they can prescribe medicines for the family and for themselves. So they gain us a privilege during the COVID-19, but we were not trained before. And hence we have a surprise today, because we have something to announce that we just launched the first in the history of Poland, the prescribing course, independent prescriber course.
Wow. And
we are going to show an advertisement in the end. And this is a very good course because we will provide 67 education points. And this is actually interesting because in 5 years, pharmacists need to gain 100. So over 3/4 of that is done in the course, 3-week course. So we'll advertise it shortly. And if there are no questions, I hope you like it and you enjoyed this evening with us. Thank you very much. For some, it's actually the evening. For some, it's morning. So you just start your day. So Jamie, thank you very much for being with us.
Thank you so much for having me. And
tonight, and we are hoping for more. And thank you very much for everybody, and also send greetings to Regis. I hope he's watching us at least for a moment. Regis, thank you very much for this, and you're running a great project. So thank you very much.
Yes, thank you so much, everyone. I really appreciate it. And the presentation will be available, like Piotr said, in Polish. So he will send it out if you need it.
Okay, Canada stamp here. Do you remember? It's from
yes. Excellent.
Yeah, good old times. Thank you very much.
Thank you so much, everyone.
Thank you, and just watch the advert. The advert is quite interesting. So Jarek, please put the advert.
Szanowni Państwo, drogie koleżanki i koledzy farmaceuci. Mam na imię Piotr Merks, jestem kierownikiem kursu Prescribing farmaceutyczny Pro Familie Pro Autore. Szanowni Państwo, czas pandemii to czas, w którym nasza profesja szczególnie zyskuje. Jednym z takich przywilei było właśnie uzyskanie możliwości przepisywania recept Pro Familie Pro Autore. Jednakże proces przepisywania jest procesem bardzo wymagającym, ale również wymagającym dużej wiedzy. Z uwagi na to, że nikt wcześniej nie przygotował tego typu szkolenia, abyście Państwo w sposób pewny, bezpieczny przepisywali leki dla swoich rodzin, ale również dla siebie, postanowiliśmy wyjść naprzeciw tej potrzebie i w ramach Polskiej Grupy Farmaceutycznej Działu Innowacji i Badań Naukowych wspólnie ze swoim zespołem przygotowaliśmy dla Państwa ten kurs. Kurs jest wyjątkowy po pierwsze z uwagi na to, jakich gości zaprosiliśmy do współpracy. Są to lekarze, farmaceuci kliniczni, ale również eksperci. Że tak powiem, osób, które bardzo nam tutaj pomagały. Jednym z bardzo ważnych elementów tego kursu jest to, że możecie zdobyć aż 67 punktów edukacyjnych. Jest to wyjątkowy kurs, wymagający pracy podczas weekendów. Są to 3 spotkania weekendowe, do których Państwa serdecznie zapraszamy. Na pewno ilość wiedzy, którą Państwo zdobędziecie, jest wyjątkowa oraz wyjątkowo przydatna w Waszej codziennej praktyce. Jednocześnie chciałbym serdecznie podziękować wszystkim wykładowcom oraz całemu zespołowi Polskiej Grupy Farmaceutycznej, tutaj Działu Innowacji i Rozwoju za merytoryczny wkład, ale również za ciężką pracę w przygotowanie tego kursu. Dziękuję Państwu serdecznie, zapraszamy.